Hello everybody, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. And as you will see him most of the times with me in this show, I have with me Dr. Pranadeep. Welcome you Pranadeep.
Hello,
For
everyone.
your own channel, okay, Urogynecology for Beginners. So today's discussion is about a very common topic about overactive bladder, and recently I happened to give this topic as a lecture in one of the webinars, so I thought I'll share the concept with you also. But before I start the lecture per se, I want to know from you Pranadeep that what is your experience with urgent continence or overactive bladder. Why I'm asking you, let me tell you this, because if you don't know, Pranadeep has recently come to the world of urogynecology. He was a big-time laparoscopic surgeon where he was working earlier. He is a laparoscopic gynecologist, basically does a lot of laparoscopies and vaginal surgeries, but maybe the exposure for urogynecology as a specialty field he was not having till now.
Yes, no. Actually, we do come across a lot of patients with stress urinary incontinence and overactive bladder. And to be frank,
he's talking from a routine gynecologist, regular gynecologist perspective.
And when we come across such patients, what we do routinely is send for an urine routine microscopy and send the urine culture and try to treat if they have any urinary infections with the antibiotics. And then most of the times we will refer those patients for urodynamic studies, especially to the urologist.
Yeah, that's what I wanted to hear.
If still the problem doesn't persist, most of them we will refer to the urology for further evaluation and treatment.
So Pranadeep, one thing you said that these patients presenting to gynecologists is not rare, number one. Second very important thing you said that most of the times any urinary problem, as was taught to us 20-30 years ago, even during my PG, they said that any urinary problem means treat with antibiotics. So that is the common practice. Third thing, and maybe the most important concern for me, is you were very honest in saying that you usually people tend to send them to urologist. Now, what do you think is the problem? Why these women are not sent to urogynecologist? 1, 2, 3, 4, some causes. Can you enumerate?
Ma'am, what I believe is most of the times we don't have much urogynecologists around.
Yes.
And
the number is very less even in India. You can count it on fingers.
Yes, ma'am. And the urologists and these patients mostly they may require urodynamics, most of them. So, and urologists are available to us all the time, and we are known to them. So we will refer these patients to urologists. Rather than to a urogynecologist whom we don't know where they are.
So correct, very well said and very practical point. So all urogynecologists out there, become visible, show your visibility, be friends with surgeons and with gynecologists so that they start calling you more and more.
And I think we should change the perspective now, ma'am. There should be more and more training programs and to make more gynecologists subspecialty programs into urogynecology.
Yes.
So that we ourselves can take our
specialty further and treat the women.
Treat the women with
urinary. We have this responsibility and we should carry out this responsibility. So based on all these things only, Pranadeep, what I'm going to do, I'm going to tell some 10-12 simple points in a form of a lecture, which actually every gynecologist and any gynecologist can adopt. These are just extension of what we are doing routinely. Nothing special, nothing specific, and you will start seeing the results. And if then also your patient does not improve, because what I think that when the patient with urinary incontinence comes to you, that time only she has broken many barriers and she has come out with difficulty to present and share her problems with you. If you are sending her to another doctor and to another doctor, then patient gets more fear and think that this has no solution and does not get treated properly. And this message percolates into the society that there is no treatment and it is part and parcel of life and you have to live with it. So with this, let's start the discussion on urgent continence, or what we commonly call as overactive bladder. Overactive bladder, considered as one of the boring, mundane and complex topic. Let's try to simplify it today and make it a bit more interesting. To do that in next few minutes, first we'll try to understand the definition and its causes. Then I will take you through the history, just 10 points in history and exactly 10 points what we must examine in these women. Only 4 investigation, trust me, only 4 investigations and many management options. More than 6 management options we'll discuss about overactive bladder. So unlike stress urinary incontinence or SUI, which is a simple single disease problem, overactive bladder is an entire spectrum which may present to you as urgency or on the other extreme as leaking with urgency, that is urgent continence. Usually it is associated with frequency in nocturia too. This syndrome of overactive bladder can present with multiple pathologies which may be directly related to bladder or indirectly related to it. These include cystitis, painful bladder syndrome, bladder stones or other irritants like eroded mesh following a mid-urethral sling surgery, upper motor neuron lesions, and sometimes it may be just like that without any cause. We call it idiopathic detrusor overactivity. All these reasons which I just mentioned may manifest as a disease through 3 pathophysiologies. 1. The bladder muscle is overactive. 2. Bladder is less compliant, can't stretch. We call it small bladder in simple terms. Or it becomes hypersensitive, little urine and it contracts. I often say to understand overactive bladder in simple words, one may call it angry bladder that gets irritated on anything and even nothing. Now, when a patient presents to you, the first step is to take her history. 10 important questions should be asked in a case of urgency or urge incontinence. First of all, we should know where our patient stands in the spectrum of just often on urgency to actual urinary leak. Number 2 is the duration of her symptoms. If the symptoms are there for days and weeks, we must rule out infection. But if it is there from months to years and is progressing over the period, it is likely to be overactive bladder. As a third of women who present with urinary incontinence have mixed incontinence, it's important to know if the patient is having coexisting SUI. Because in these women, you must strategize and plan the treatment in a different way to achieve a successful outcome. Next is daytime frequency and nocturia. These 2 symptoms are usually seen with overactive bladder. A normal daytime frequency is usually 7 to 8 per day. You need to ask if patient has more or less. Many times, less frequency, which is seen in underactive bladder, may present with leaking before reaching the washroom, which may be confused with an overactive bladder. For nocturia, 1 to 2 times going to washroom in the night is normal, but more than that is considered abnormal and is called as nocturia. If your patient has nocturia, ask her 2 questions. First one, if she sleeps well and gets up because of sudden urge to pass urine, or if she goes multiple times to washroom as she is not able to sleep well. Nocturnal enuresis or bedwetting again should be asked if it happens without her knowledge or suddenly follows a strong urge. Associated pain abdomen favors the diagnosis of UTI or painful bladder syndrome. More water intake and antibiotics, which are usually advised by primary care physicians, may give some relief to the symptoms of overactive bladder but will not be able to completely cure it. In cases of complete resolution of symptoms with antibiotics, again think of recurrent UTI. Last but not the least, history of comorbidities is very important. Diabetes can cause the symptoms because of predisposition to recurrent UTI or cystitis and also because of peripheral neuropathy. In musculoskeletal and neurodegenerative diseases, patient may not have overactive bladder, but as she can't reach the washroom on time, thus may leak on the way, which may present at face value as overactive bladder. Drugs like some antihypertensive, diuretics, and psychotropics may mimic overactive bladder syndrome. Pelvic irradiation for malignancy decreases the bladder compliance and may lead to overactive bladder, as has been discussed earlier. When the history seems unreliable, a 3-day bladder diary is a great tool to document her symptoms. After clarifying these 10 points in history, we move on to examination and record 10 points in examination. First is her mental status and mobility, which I have already explained how it can confuse or exaggerate the severity of incontinence. In abdominal examination, look for any pelvic mass like fibroid or ovarian cyst, which may cause pressure on the dome of the bladder and mimic less compliance, or may cause recurrent cystitis by pressure on the bladder neck. Suprapubic tenderness is suggestive of cystitis or painful bladder syndrome. On local examination, signs of excoriation or urinary smell will tell about the severity and suffering of the lady. You should also look for vulvovaginal atrophy, which should be treated and can be a cause of urgency or even urge incontinence. To rule out SUI, every patient of urge incontinence should be subjected to uniform cough stress test. On speculum examination, look for cystocele and rectocele, and yes, even rectocele can cause urgency or urge incontinence. Bimanual examination to look for uterine and adnexal pathology, as every uterine or adnexal mass will not be palpable parabdominally. You must look for it in vaginal bimanual examination. Last or 10th point is digital rectal examination, which will tell you the anal sphincter tone and also will help to confirm rectocele. As far as investigations are concerned, for a case of overactive bladder, 4 investigations should be done. First is analysis of urine to rule out infection. Second is ultrasound abdomen, may be very important. It will tell you about any abdominal or pelvic masses which might be causing pressure symptoms on the bladder or causing bladder neck obstruction. It will also help you to measure post-void residual urine, that is called PVR. Urodynamics, talked a lot about when it comes to overactive bladder. We'll discuss in a while what is the role of urodynamics in overactive bladder, and cystoscopy only for those cases where you are expecting something inside the bladder, like a stone or an eroded mesh. So urodynamics. So many people think that urodynamics is a very important investigation to diagnose overactive bladder. Yes, to say detrusor overactivity, we must be able to demonstrate the peaks in the detrusor pressure graph, which can be provoked or spontaneous. But the paradox is that only half of the women who present with urgency or urge incontinence, you will find these kind of pressure changes which are unprovoked or provoked in a urodynamic trace. Moreover, half of the elderly asymptomatic adults will also show these kind of pressure changes on a urodynamic trace. So you cannot keep on treating asymptomatic women, while on the other hand, because they did not show detrusor activity on a trace, you don't stop treating or refuse treatment for women who actually are having symptoms. So as far as I am concerned, urodynamics in 60 to 70% of cases of overactive bladder in first go, they do not require any urodynamic assessment. Rather, you can start them on trial of treatment and see the response. If they are not responding to preliminary treatment, which are some simple strategies, then maybe as a second line option, you can go for urodynamics. For the management of overactive bladder, we have lot of options. Surgical options I'm not going to discuss here because they are not usually done. What I'm going to discuss are 6 options which are used in day-to-day clinical practice. First of them is behavioral and lifestyle modification, which is very simple to do. What you have to do, just manage the fluid intake strategies and timely voiding. Local estrogen also is a basic thing in cases where you find vulvovaginal atrophy, usually in old women. So I add that also in behavioral and lifestyle modification changes itself. Second management option is the bladder training. Now, what we have to make the patient understand is that you have to train this bladder, your bladder, like a baby, starting from 1 week of every hour voiding, which should be increased to 2 hours in second week, 3 hours in third week, and maintained for 3 hours in fourth week and after that. Even 15 minutes, if the patient can delay every time, that should be treated as a successful outcome. Pelvic floor muscle training, remember, it is not only important for SUI, it is very important for other kind of incontinence also, including overactive bladder, urgency, and urge incontinence. Other than strength training of pelvic floor, the other concept which is taught to these women is intentional contraction when the sensation of urge comes. Pharmacotherapy, yes, this is the mainstay of treatment, which includes anticholinergics and adrenergic drugs. And then, if patient does not respond to all of the above, then you can adopt some minimally invasive treatment options, which includes bladder botox, sacral neuromodulation, or percutaneous tibial nerve stimulation. So let's try to first understand a bit about pharmacological intervention or overactive bladder drugs. Now, which category they should belong to? The concept is simple. You can remember for peeing, parasympathetic system is required, while for storage, S is for sympathetic system, is required. So here, what we want patient to store more. So we have to give sympathetic kind of drugs more, which are adrenergic, or opposite of parasympathetic, which is anticholinergics. Though for most of the countries and most of the experts, now mirabegron, which comes under beta-3 adrenergic agonist, is the treatment of choice for overactive bladder. The other drugs which can be used are solifenacin, which is M3 select anticholinergic, or even tolterodine and trospium chloride. Among the minimally invasive therapies, if you have not seen a bladder botox, this video may interest you. So what we have to do, around 100 units of diluted botox, we have to inject into various points in the bladder wall, in the submucosal space. So every time half a ml of diluted solution is injected, and around 20 such points are created in the bladder, including the trigone. What it does, it relaxes or paralyzes to a certain extent the detrusor muscle of the bladder. And especially important to keep in mind is the fact that as the muscles are now paralyzed, you must tell her the bladder drill for at least a month to get the optimal results. The other minimally invasive option is called sacral neuromodulation. So this is the bunch of sacral nerves what we do, we place a small transducer, not inside but just touching the sacral nerves from one of the foramina, and connect it to a regulate which can regulate the rate of stimulation. Supposedly, it works throughout the nervous system, takes the sensation, awareness, feeling of urgency, and timing of voiding to the brain and gives the responses back to the bladder. Thus, it helps not only in overactive bladder but in many kinds of neurogenic overactivity also. So, it is these days a very good tool, a very useful, minimally invasive form of treatment of any kind of overactive bladder. In a nutshell, by lifestyle modification, medications, muscle relaxation, neuromodulation, keeping the angry bladder calm is the key to treat an overactive bladder. Keeping in mind these simple strategies, I hope next time a patient presents to you with urge or urge incontinence, you will feel more confident to treat the patient, and if you are not able to do so, refer her to a urogynecologist. Thank you so much.